Bismillah ar-Rahman ar-Rahim. I am Dr. Muhammad Mamdouh, lecturer of internal medicine and nephrology. Today we are discussing general examination. We will start by vital signs. Vital signs include pulse, blood pressure, temperature, and respiratory rate. Regarding blood pressure measurement, it's very important to know how to measure blood pressure accurately. Blood pressure is a measurement of force applied to artery walls. Normal blood pressure includes systolic blood pressure and diastolic blood pressure. Systolic pressure is the pressure of the blood vessel when the heart beats during each heartbeat, while the diastolic blood pressure is the pressure between beats when the heart relaxes. So systolic when the heart beats and diastolic when the heart relaxes. What regarding about the definitions of blood pressure measurement? These are the measurements according to the European Society of Cardiology 2018. When optimal blood pressure, when the systolic is less than 120 and diastolic less than 80. Normal blood pressure when the systolic is 120 to 129 and or diastolic between 80 and 84. High normal blood pressure when systolic blood pressure is 130 to 139 and or diastolic 85 to 89. Grade 1 hypertension, which is very important when you are asked about when to define hypertension, when the systolic blood pressure is 140, more than 140 or more, 140 to 159, and or diastolic 90 to 99. Grade 2 hypertension when systolic blood pressure between 160 to 179 and or diastolic 100 to 109. Grade 3 hypertension is systolic blood pressure 180 or more and or diastolic blood pressure 110. Isolated systolic hypertension is defined as systolic blood pressure 140 or more and diastolic less than 90. There are variations between guidelines regarding definition of hypertension and blood pressure, but most of them define hypertension as having systolic blood pressure 140 or more and diastolic 90 or more. Hypotension is defined when systolic blood pressure is less than 90 millimeter mercury and or diastolic less than 60 millimeter mercury. These are various devices to measure blood pressure, including sphygmomanometer using mercury and automated devices. What are the blood pressure reading and what are the interpretations? Systolic blood pressure, we increase the pressure through the inflatable cuff till occlusion of the artery. When the artery is completely occluded, there is no sound. The sound is passage of blood during the opened blood vessel. So we inflate the cuff to occlude the artery. There is no sounds at first. Then we relieve this inflation gradually until it is opened. Once it's opened, this is a systolic blood pressure. It is when the sounds is heard first. Till complete absence of sounds when the artery is completely opened. This is the diastolic blood pressure. What are supports of the sphygmomanometer? It includes an inflatable rubber cuff, which is should be for the appropriate size for the patient. A pediatric patient have a different size, adult patient has different size, and obese patient has another bigger size. This is air valve, this squeezable bulb, and this, of course, the stethoscope. What are the rules to measure blood pressure? A lot of doctors and many persons in our life measure blood pressure, but it is not accurately. During the recent guidelines, there is a whole chapter of how to measure blood pressure. How to measure blood pressure. The patient should be sitting after 5 minutes rest, should be at rest. The patient should be supported, his back, feet, and arm. The cuff should be at the level of the mid-sternum. It shouldn't be wrapped very tight or very loose. The two rubber tubes should be at the middle of the cubital fossa. The manometer is placed at the same level of the observer's eye and cardiac level of the patient. The diaphragm of the stethoscope is positioned at the lower margin of the cuff, not completely below the cuff. It's a common mistake, at the lower margin of the cuff. Then after the patient is positioned at this correct position, we start by doing palpatory method, then auscultatory method. What is palpatory method? Palpatory method, we measure the systolic blood pressure by palpation, by our hand. At first, to get the systolic blood pressure. Why we doing that at first? To avoid what is called auscultatory gap. This diagram will illustrate. Sometimes when the patient, his true blood pressure, for example, is 160 over 80. 160 over 80. Sometimes we hear the first sound at 160, which is a systolic blood pressure. And then sounds appear, and suddenly there is disappearance of sounds for a gap. For example, at 140 and to 120, or 140 to 130, and then sounds return again. So if we don't get our systolic blood pressure by palpatory method, we might elevate the blood pressure to 130. It is at the auscultatory gap when there is no sound. So I falsely get it at 130. When the sounds reappear, it is systolic blood pressure, which is a common mistake. So at first we get the systolic blood pressure by palpatory method. So then we elevate more during auscultation by 20 to 30 millimeter mercury, and then we decrease it to avoid being positioned at the auscultatory gap. Also, we know the systolic blood pressure first to avoid increasing. Sometimes some of doctors elevate the blood pressure without knowing systolic to more than 220, 230, and the patient actual systolic blood pressure is 140. This is too much. This will cause pain. This will stimulate sympathetic nervous system, will increase the blood pressure. This is wrong. So we do palpatory method for two things: to avoid the auscultatory gap and to avoid more pain causing elevation of the blood pressure. After we do palpatory method, and we know through palpatory method the systolic blood pressure, we do auscultatory method. We elevate the blood pressure by about 20 to 30 millimeter mercury above the palpatory systolic blood pressure. For example, I get it by palpatory systolic blood pressure at 130, so I elevate during auscultatory at first to 150 or 160, and then I decrease the blood pressure by opening the air valve. When I hear the first sound to appear, it is a systolic blood pressure. Till disappearance of sounds completely, this is diastolic blood pressure. So the first sound I hear is a systolic blood pressure, and disappearance of sound, it is the diastolic blood pressure. This is the Krotkov sounds. Krotkov sounds are sounds here during auscultation or measurement of blood pressure. What is important for us? First sound is it is a systolic, and last or disappearance of sound at silence or phase 5, this is the diastolic blood pressure. Next step during blood pressure, do I finish? No. After measurement in one arm, I should measure the blood pressure in the other arm. I should measure the blood pressure in the lower limbs, and I should measure the blood pressure after letting the patient stand for 1 to 2 minutes. This is very important. Sometimes in the exam, the auscultation is too short for you to do that. You should tell the examiner that I should measure the blood pressure in the other arm, I should measure the blood pressure in the lower limbs, I should measure the blood pressure after the patient stand for 1 to 2 minutes. A common question for doctors: which arm I should use? Which arm I should use? We should measure the blood pressure in both arms, and I got the higher reading. I should measure the blood pressure in both arms, and I use the higher reading. This is very important. Is there a difference between blood pressure measurement in both arms? Yes, it's acceptable to have a difference less than systolic over diastolic 10 over 5. This is accepted. But when the difference is more than 10 millimeter mercury systolic or more than 5 millimeter mercury diastolic, this is problematic, and I should search for peripheral arterial disease in one side, like atherosclerosis or thrombus or embolus, or external pressure at one side by cervical rib or hematoma or tumor, or if there is coarctation before the left subclavian artery. So it is accepted to have a difference between both upper limbs up to 10 over 5. When it is more, I should search that there is decreased blood flow at one side of either arms. For peripheral in the lumen there is a problem, or there is external pressure on or in the blood vessel wall. In the blood pressure in measurement in the lower limb, we measure the blood pressure over the popliteal artery or the posterior tibial artery. This is very important. Some of our patients have problems in both hands, and we cannot measure blood pressure, which is a common scenario, like in patient doing hemodialysis, having arteriovenous fistula in both arms. We cannot measure the blood pressure in arms. We use the blood pressure in the lower limbs. Blood pressure in the lower limb, it is lower or higher than the upper limb. Of course, it is higher than the upper limb. It is accepted to be higher up to 20 millimeter in systolic and 10 millimeter in diastolic. Up to. When it is in the lower limb higher than that, when the blood pressure in the lower limb is higher than the upper limb by more than 20 millimeter mercury systolic, I should search for aortic regurg. It is called the health sign. But when the lower limb blood pressure is lower than the upper limb, I should think that there is decreased blood flow to the lower limbs, like in coarctation, or a local disease like peripheral vascular disease or external pressure. So in blood pressure in lower limb is higher than the upper limb. That's normal. Normally it is higher up to 20 millimeter mercury over 10 millimeter mercury, systolic over diastolic. When it is higher than that, I should think of aortic regurg. When the blood pressure on the lower limb is lower than the upper limb, I should think of coarctation or peripheral vascular disease. As I told you before, that we should measure blood pressure after letting the patient stand for 1 to 2 minutes. This is very important to diagnose or to think if there is postural hypotension or not. Normally, when the patient stands, there is more increased vasoconstriction, and the autonomic response will try to maintain the blood pressure. We usually find there is slight drop in the blood pressure after the patient stands for 2 minutes. But if there is a fall in the blood pressure more than 20 millimeter in systolic and more than 10 millimeter in diastolic, this is called postural hypotension. So what is definition of postural hypotension is fall in systolic blood pressure after more than 20 millimeter and diastolic more than 10 millimeter mercury after standing for 1 to 2 minutes. What are the causes of this postural hypotension? As I prescribed, if there is defective autonomic response after the patient stand, like in patient with autonomic neuropathy, the most common cause is diabetic neuropathy. Also, we find it in hypovolemia, old age, and some drugs like direct vasodilators and diuretics. We should take care of that, especially in elderly patients, because they might get falls. We finish by that blood pressure. Now we go for temperature. How to measure temperature? This is very important by various methods, using oral temperature, rectal temperature, which oral temperature is a standard. What's meant by standard? When I measure in oral temperature, it is the same reading. Rectal temperature, I decrease the reading by 0.5 degree. Axillary temperature, I increase 0.5 degrees to the reading. Also, we can use tympanic measurement by during using the ear, or digital examination, digital measurement of temperature. Normal temperature is 36.5 up to 37.2. Pyrexia is defined as having temperature more than 37.2. Hyperpyrexia, when the temperature is more than 41. Subnormal temperature, when the temperature is less than 36.5. Hypothermia, when the temperature is less than 35. How to measure temperature? At first, I should greet the patient and introduce yourself to the patient. Prepare the thermometer and the alcohol and cotton balls. I should wash my hands, hold the thermometer at the end of the stem at my eye level. I rotate it slowly until the mercury is back and it's clearly visible. I should wipe the thermometer by cotton balls and alcohol from the stem to the pulp. I should shake the thermometer down to 35 degrees using quick and sharp wrist motions. To do for axillary method, the patient should be lie in the supine or semi-sitting position. The patient axilla should be clean and dry. I should hold the patient arm firmly to the side with the elbow flexed and his hand in contact with his chest. We should wait for at least 3 minutes. We should wait for 3 minutes. Then I remove the thermometer and dry it by wiping it by cotton balls. And then I should read the thermometer by rotating the stem until the mercury is clearly seen. As I said before, auxiliary temperature, we should add 0.5 degree to the measured temperature. For the oral method, I should ask the patient to open his mouth and raise his tongue, and we put the thermometer at the base of the tongue. And ask the patient to relax his tongue and close his lip firmly over the thermometer. Again, we should wait for at least 3 minutes. After that, we remove the thermometer and remove any secretions by wiping it by cotton, and then we read the temperature. What are causes of fever? This is very important. Most importantly, and the most common cause is infections like bacterial, viral, fungal. Some inflammatory causes like systemic lupus erythematosus and rheumatoid arthritis might cause fever. Also malignancy like lymphoma and leukemia, hematological diseases, allergic reactions, and myocardial infarction and pulmonary embolism might cause slight increase in body temperature. What are the causes of hypothermia? The most common cause is cold exposure and hypothyroidism. Regarding respiratory rate, normal rate for respiration differs according to the patient age. For adult, it is from 12 or 14 up to 20 breaths per minute. We should measure the breath or the respiratory rate for a whole minute. When the respiratory rate is more than 20, it is called tachypnea. Usually, physiological causes of tachypnea, exercise, as we all know. If there is some pathological cause like acute respiratory distress, bronchial asthma, pneumonia, pulmonary edema, patient cannot take his breath, or heart failure, fever, anemia, thyrotoxicosis, or psychogenic. When there is an anxiety, it will cause increased respiratory rate. When the respiratory rate is less than 12, it is called bradypnea. It is observed when there is decreased respiration, like in chest deformities, myositis, pleurisy, and neurological central nervous system depression, while most important by drugs like opioids or hypnotics, or in patient with hypothyroidism. Regarding pulse. Pulse is defined as the propagation of the ventricular contraction along the blood vessels. It is felt by applying soft pressure on the artery according to a hard surface. Mostly it is a bone. The most common artery to be used is the radial artery. At first, we should grade the patient and introduce yourself. We assist the patient to pronate his forearm and slightly flex his forearm. We feel the pulse by using the tips of the middle 3 fingers. We use the middle 3 fingers and press gently till we feel the pulse. What should I comment for the pulse? This is very important. I should comment on the rate, rhythm, force, volume, equality on both sides, vessel wall, special characters, and peripheral pulsations. And we'll discuss each one of them in details. Heart rate, we should measure or count the pulse in 1 minute. And if the rhythm or the pulse is irregular, we should measure it or count it in 3 minutes. Normal heart rate is from 60 to 90 beats per minute. When it is more than 90, it is called tachycardia. When it is less than 60 beats per minute, it's called bradycardia. Tachycardia, there is physiological causes like exercise and emotions, or pathological causes in fever, heart failure, thyrotoxicosis, and sympathomimetic drugs. Bradycardia in athletes, old age, or in some pathological diseases like myxedema or digitalis overdose or heart block and obstructive jaundice. Rhythm. What is rhythm? A rhythm is the interval between beats. Each beat should be followed by the next beat at the same duration. When each distance or the interval is equal between each beat, it is called a regular rhythm. When there is abnormality in that rhythm, it is called irregular rhythm, or the distance between each beat, it is called irregular rhythm. And this irregularity might be either regular or irregular. Again, rhythm might be regular, which is normal, or abnormal, it is irregular when the distance or the duration between each beat is different between different beats. And this irregularity might be regular. Like for example, I have a premature beat after each normal beat. So it is regular. It is irregularity, but regular. And sometimes I have premature beat, sometimes after one beat, and then after two beats, and then there is a pause, and then after two beats, then after three beats. So there is irregularity, and this irregularity is irregular. So it is called irregular irregularity. Regular irregularity. This means that there is irregularity, but this irregularity is present in a steady pattern, in a regular pattern. For example, if you look here, there is a premature or a beat after each beat. This is the normal beat and then abnormal beat. There is a normal beat and there is abnormal beat. There is a normal beat and there is abnormal beat. So there is irregularity. How we know the irregularity? We should measure the distance between different beats. This distance is short, so then followed by long distance, short, long distance. So at first, when you look, there is irregularity. Then we should search for this irregularity. It is regular or not. After a close look, we find that this irregularity is regular. This abnormal beat is following each normal beat. This is called pulsus bigeminus. What about pulsus trigeminus? If you look here, the distance is different. This distance or duration is more than that, and then a long one, and then a short one, then a short one, then a long one. So there is irregularity. This at first. If we look at it, we find irregular beats here, here, here. But with a closer look, we find that this irregular beat is present after each two normal beats. 1, 2, abnormal. 1, 2, abnormal. 1, 2, abnormal. So there is irregularity, but it is regular. So this is called pulsus trigeminus. Pulsus trigeminus. What about irregular irregularity? There is irregularity, but it is irregular, completely irregular. The most common causes is atrial fibrillation and extrasystoles or multiple premature beats. How to differentiate between both of them? We try to count 4 to 6 successive regular beats. If I count 4 to 6 successive regular beats, it is mostly extrasystole. If we do exercise, extrasystole will disappear, while atrial fibrillation will become worse. Vagal maneuvers will have no effect on extrasystole, and it will decrease the atrial fibrillation. Pulse deficit. What is pulse deficit? It is the difference between the pulse rate at the radial artery and the heart rate at the level of the heart, at the apex of the heart. It is the difference between the heart rate and the radial rate. In extrasystole, it is less than 10. And in atrial fibrillation, this pulse deficit, or the difference in rate in atrial fibrillation, is more than 10. Regarding force, now we have talked about rate and rhythm. Then we will go for force. What is force? Force, it is the external pressure needed by me, by the examiner, external pressure by the examiner to occlude the artery. So it is the pressure needed by the examiner to occlude the artery or to occlude the blood flow. This is very important. It correlates with what? It correlates with the systolic blood pressure. It correlates with the systolic blood pressure. So what is force? Is external pressure needed to occlude the artery. It correlates with the systolic blood pressure. Normally, what is our command? It is average force. If it is increased force, what is meant by increased force? That I have more force to occlude. I need more force or exaggerated force to occlude the artery. It means what? It means that increased force, it means that there is increased systolic blood pressure. But if I need lesser force or a decreased force to occlude or little pressure to occlude the artery, this means that the force is decreased and the systolic blood pressure is low. What about volume? Volume is the opposite. Force, it is the amount of pressure exerted by me to occlude the artery. Volume, it is the amount of elevation. It is the amount of elevation of the blood vessel to my fingers. It is the opposite. It is the amount of elevation of the blood vessel to my finger. This is volume. It reflects what? It correlates with what? It correlates with what is called pulse pressure. What is pulse pressure? Pulse pressure is the difference between the systolic blood pressure and the diastolic blood pressure. Normally, it is average volume. It is average volume. When it is increased volume, what is meant by increased volume? That there is higher elevation to my fingers by the blood vessel. It is called hyperkinetic pulse. Or decreased volume, that the elevation of the blood vessel to my finger is decreased. This means that decreased pulse pressure. Decreased pulse pressure. What are the causes of abnormal volume or hypokinetic or decreased volume? It means that decreased pulse pressure, or hyperkinetic, that increased volume or increased pulse pressure. Hypokinetic or decreased pulse pressure is present when there is low cardiac output, like in heart failure or shock state, cardiomyopathy, or there is peripheral vasoconstriction in hypovolemia. Hyperkinetic pulse, when there is increased volume, increased pulse pressure, like in case of atherosclerosis, aortic regurg, or in hyperdynamic circulations. It's very important to know them. Hyperkinetic states or hyperkinetic or hyperdynamic circulation is present in fever, anemia, thyrotoxicosis, arteriovenous fistula, and pellagra. These are the causes of increased volume. Increased volume. Fifth item to comment on pulse is the character or the type of pulse. Normally, there is a gradual ascent for pulse, there is a descent, and there is a diacritic notch, and then it decreases. This is the normal pulse wave. This is the normal pulse wave. Normally, there is no special character. No special character. Yani it is normal pulse. But if we find it that pulse is hypokinetic or thready, it is called thready pulse. Weak rapid pulse, like in shock state, or it is higher or hyperkinetic, like we said before, in increased volume or increased pulse pressure, it is called bounding pulse. Bounding pulse, when the pulse pressure is high, that there is more elevation to my finger. Water hammer pulse or collapsing pulse is present when there is exaggerated form of the bounding pulse, when there is increased pulse pressure, high increase of pulse pressure. Most importantly, we find it in aortic regurg and arteriovenous fistula type. How to detect water hammer pulse? This is very important. We should raise the patient arm above the level of the heart, like we see here. Patient arm and forearm are elevated above the level of the heart, and then we feel the forearm muscles here and artery, we feel the pulsation. If we feel pulsations or exaggerated pulsation, this is water hammer pulse, denoting that increased pulse pressure, increasing volume status. Another abnormal character is plateau pulse, when there is no summit. Plateau pulse is present in aortic stenosis. Pulsus bispherians, when there is two peaks, not only one peak, when there is two peaks during systole, it is present in double aortic lesions and in hypertrophic cardiomyopathy. Diacritic pulse, when there is two peaks, one peak during systole and the other one in diastole. It's present in some types of fevers. Pulsus alternate beats that are strong and weak. Strong alternative beats, strong beats, and weak beats. It's present in massive myocardial infarction and myocarditis. Pulsus paradoxus is very important to know. Pulsus paradoxus, all of what I described is abnormal pulse. Abnormal pulse. In normal situations, there is no special character. Pulsus paradoxus is defined as exaggeration of the normal phenomenon. exaggeration of the normal phenomenon. But what is the normal phenomenon? Blood pressure, normal phenomena is defined that during inspiration, the blood pressure normally decreased blood pressure, but less than 10 millimeter mercury. It is not palpable by my hand. I cannot detect it in normal situations. This is normal phenomenon. Normal phenomena that during inspiration, the blood pressure decreased but less than 10 millimeter mercury. But if there is exaggeration of that normal phenomena, that during inspiration the blood pressure falls more than 10 millimeter mercury, and I can palpate it and I detect it by sphygmomanometer, this is called pulsus paradoxus. This is present in cardiac tamponade, constrictive pericarditis, and obstructive airway diseases. Sixth item to comment is arterial wall condition. Is the sixth condition, arterial wall condition. It is detected by milking the artery and roll its wall against the bone. Normally, it is not felt. The arterial wall is not felt because of there is elastic tissue. But if I felt the blood vessel as cord-like, it is present in atherosclerosis. Seventh item to comment is equality on both sides. As you see here, this is how we comment on equal pulse on both sides. We comment regarding the force and volume. We comment as regards it is equal on both sides regarding force or volume or not. If it is unequal, I should think of apparent radial artery. Apparent, it means that it is not present at its normal place or normal surface anatomy, or there is arterial compression at one side, compression from the outside, like by cervical rib or lymph nodes, or there is arterial thromboembolism inside the lumen, there is obstruction, or there is in the wall there is coarctation of the aorta, decreasing the blood supply to one side, or there is aortic aneurysm and aortic dissection. The last item to comment during our examination for pulse is the other pulsations, different pulsation. I should comment whether I felt other pulsations or not, and it is equal, bilateral or not. Of course, it should be felt and be equal in normal situation. If it is not felt or it is not equal on both sides, I should think of causes of unequal pulse. What I should examine for peripheral pulsations, we examine radial artery, but I should examine brachial artery, carotid artery, femoral artery, popliteal, posterior tibial, and dorsalis pedis. Some doctors will go for dorsalis pedis. It is the most distal one, and think that if it is felt, it means that all the blood pathway is okay till the distal circulation. This is the brachial artery, which is felt at the elbow, medial to the biceps tendon. Carotid artery is felt at the neck, medial to the sternomastoid. Muscles. It is detected by compressing or causing pressure against the transverse process of the cervical vertebrae. And it is important to highlight that we shouldn't examine carotid artery bilateral at the same time. We shouldn't do that. Lower limb pulsation, this is femoral pulsation. Femoral pulsation is felt below the inguinal ligament, which is present between the anterior superior iliac spine and the symphysis pubis. We go for the mid-inguinal point and go half a centimeter below it. This is the site to examine the femoral artery. Posterior popliteal artery, we should put the patient knee flexed, and as you see here, and we'll see on clinical examination, we felt the popliteal artery in the popliteal fossa. Posterior tibial artery, it's felt midway between the medial malleolus and tendo-Achilles tendon, and dorsalis pedis artery is felt proximal and on the foot, proximal lateral to the tendon, very important, of extensor hallucis longus. It is the tendon for the muscle supplying the big toe. We felt the dorsalis pedis lateral to the tendon of extensor hallucis longus. So, to conclude or to summarize the pulse comment, how to examine pulse, I should comment on the rate, rhythm, force, volume, equality on both sides, vessel wall, peripheral pulsations. It's very important, and know how to comment for on the normal situation, and if there is abnormal, what to say. Thank you. Now we are going for clinical examination. Good morning. I'm Dr. Muhammad Mamdouh, lecturer of nephrology and internal medicine. Now we are going to do clinical examination for vital signs. We will start by blood pressure measurement. As we described before, for the measurement of blood pressure, the patient should be positioned correctly. His back should be supported, both his arm and his legs. At first, you should introduce yourself to the patient, of course. And then we put the inflatable cuff. This is the proper position. And we should wrap it tightly, but not very tight. And the tubes should be medially at the middle of the cubital fossa. At first, we measure the palpatory method. We put our middle 3 fingers over the radial artery, and then we elevate slowly the mercury till absence of the pulse. It is absent now. 3 appears again at 120. So systolic blood pressure by palpatory method is 120. What we do, we remove, we deflate the cuff, and then we do the auscultatory method. We put the diaphragm of the stethoscope at the lower edge of the inflatable cuff, and we elevate the mercury by 20 to 30 millimeter mercury above what we got in the palpatory method, which is 120. And then we decrease the blood pressure slowly, 2 to 3 millimeter mercury each second. And we hear the sound. The first sound is the systolic blood pressure, and when the sound disappears, this is the diastolic blood pressure. The first sound appeared at 120, and the diastolic one or disappeared sound at 80. So our measurement for blood pressure now is 120 systolic over 80 diastolic. We should measure for in the other upper limb, and we should measure in the lower limb, and we should measure after the patient stand for 1 to 2 minutes to detect postural hypotension. This is blood pressure measurement. Then we will examine pulse, radial pulse. To comment on radial pulse, we should comment on items: rate, force, volume, special character, equality on both sides, vessel wall, and peripheral pulsations. To examine radial pulse, we use our middle 3 fingers. The distal one will occlude the collaterals. The proximal one will allocate the artery and compress it. By the middle one, we feel the pulse. To count or comment on the rate, we should measure the pulse rate for 1 minute. It is 78 beats per minute. Regarding the rhythm, which is the interval between each beat and the next beat, it is regular rhythm. regarding force, which is the amount of pressure exerted by my finger to occlude the artery. It is average force. Force correlates with the systolic blood pressure. The next item is volume, which is the amount of elevation exerted by the blood vessel to my finger. It is average volume. Volume correlates with the pulse pressure. After that, we comment on equality on both sides. We examine radial pulse bilaterally at the same time regarding force and volume. It is equal on both sides. Regarding vessel wall assessment or examination, we do rolling method. It is not felt, which is normal. Regarding peripheral pulsations, we examine brachial artery at the cubital fossa, medial to the biceps tendon. Felt. Regarding carotid artery, it is felt in the neck, medial to the sternomastoid muscle, against transverse process of cervical vertebrae. Felt. Now we are going for examination of peripheral pulsation on lower limbs. In the blood, regarding pulse examination to felt pulse in lower limb, we should examine for femoral pulse, popliteal artery, and dorsalis pedis. Now we are going to feel the peripheral pulsations in lower limb. We are going to feel dorsalis pedis artery. Dorsalis pedis artery is felt proximally in the foot, lateral to the tendon of extensor hallucis longus. We trying to grab the big toe, and this is the extensor hallucis longus tendon, and we feel the dorsalis pedis artery here. It is felt. When it is not felt or it is weak, we might think of peripheral arterial disease. Now we are going up for the popliteal artery. For popliteal artery examination, we flex the knee and we feel the popliteal artery in the popliteal fossa. We do it by that. To put my fingers in the popliteal fossa. It is felt. Now we are going to examine the femoral artery. Femoral artery, it is felt at the upper part of the thigh, at the inguinal ligament, which is present between the anterior suprailiac spine and symphysis pubis. At the midpoint of the inguinal ligament, we go half centimeters below. Femoral artery is felt. This is how to comment for pulse. We comment on rate, rhythm, force, volume, special character. Regarding the special character, there was no special character in the patient, in our patient, and we describe the different abnormal pulsations that we can get, but there is no special character. How to comment after we finalize? Like in our patient, it is 78 beats per minute, regular rhythm, average force, average volume, no special character. It was equal on both sides, vessel wall not felt, and the peripheral pulsations was felt. Now we are going to do temperature measurement. At first, we hold the thermometer in our hand like that, and we try to allocate the mercury, and then we should wipe the thermometer from the stem to the bulb by cotton ball with alcohol, and then either we are going to measure it axillary or oral. We will use the axillary method. Axilla of the patient should be dry and clean. We put it in the axilla and close formation, and the patient arm will be flexed on his chest. And we should wait for 3 minutes. For axillary measurement, we should add 0.5 degree. If we use the oral method and we put the thermometer below the tongue, it is the same reading, but in axilla we increase 0.5 degrees, or in rectal method we decrease 0.5 degrees. During that, while we are waiting the measurement, we will count respiratory rate. When you are going to comment on the respiratory rate, you shouldn't tell the patient that you are counting his respiration, because some patients might exacerbate their respiration to make you feel that they are sick. But we are pretending that we are some method, we are pretending that we are counting pulse, but we are actually counting respiratory rate. And we are counting respiratory rate in 1 minute. It's about 18 breaths per minute. Normal respiratory rate is from 14 to 20. More than 20 breaths per minute, it's called tachypnea, while less than 12 or 14, it's called bradypnea. We are waiting for the temperature to get the exact reading. To remember that we are doing vital signs during blood pressure. Don't forget the correct position of the patient to make him supported, to make him at rest first, and then we do the palpatory method, then the auscultatory method. Don't forget to measure the other upper limb and the lower limb, and after letting the patient stand for 1 to 2 minutes. This is very important to remember. And while you are examining pulse, don't forget the items we are going to examine. This is very important to know and not to take time. Now we remove the thermometer. After we remove the thermometer, we should wipe it by the cotton. And we'll go to rotate until we see the mercury. It is here at 36, and then we add 0.5 degree because we measure it in the axilla. So it is 30, the patient reading for temperature is 36.5. Thank you.